Hi everyone. So as Lisa has said, I'm an ENT doctor and I did a PhD focusing on tinnitus and neuroimaging. And now was really glad when Lisa asked me to talk a little bit about tinnitus and pediatrics. I'm now doing a lot of clinical work in a pediatric hospital and therefore I'm seeing quite a lot of children with tinnitus. So we are going to do a talk that is a little bit more or focused on clinical information. But even though if you're mostly a researcher, you might find interest into having this information about what actually it is to manage patients that have tinnitus in the clinical settings. So when we are talking about tinnitus patient or when we do think about tinnitus patient, most of the time we have these images that comes into mind, either people that are kind of old with a hearing loss that gradually arrived, or adult patients that are really distressed by their tinnitus and don't know how to cope with the tinnitus. But most of the time we don't have these images. We don't have a little child of 5 or 6 years old that comes to the clinics and complain about tinnitus. And when we talk about tinnitus in children, and actually even my ENT colleagues, sometimes one of the questions that they have is, do children actually have tinnitus? Because in clinics, it's not that frequent to have a child that come that have a problem of tinnitus, so actually do a consultation mostly focusing on tinnitus. It is most frequently kind of a adult complaint. So do children have tinnitus, or do they have tinnitus as much as adults? Well, part of the answers come from a great review paper that was published kind of 10 years ago that look at all the literatures about researchers that I've asked children the question about tinnitus. Do they hear sounds? Do they hear buzzings? And actually the prevalence of tinnitus, so the percentage of the population they ask that do say yes to, yes, I have hearing in my ears that are not part of the environment, range from 5 to 46%, which is kind of a big number. The variability, as always in prevalence study, depends on the kind of population you are interviewing, younger or older children, but also the kind of question you're asking. But if you look at the prevalence in children that were asked about permanent tinnitus, so tinnitus that they hear all the time, we have a prevalence of 5 to 18%. So very similar to the kind of prevalence that we find in adult population, or at least the research in adult population. So this is in children who do not complain of hearing loss and who do not have hearing problem. But if you focus on children that do have hearing loss, then the prevalence increases. It is up to 1/3 to 2/3 of the population that actually complain about tinnitus. So as you see, prevalence is quite high in the children. What we can say it is that the prevalence increases if there is hearing loss, up to 2 times more frequent if there is hearing loss. And also, if you look at the age of the children, the prevalence increases with age. It is more prevalent in the adolescent population compared to the younger children. What is also important in tinnitus and especially in the children population is the timing. As you know, as human, we start to hear when we are not even born. So around the 27th, 28th week of gestation, we do have our auditory system that is functional, and we hear the sounds of the environment. And then the earrings does mature with the time, and there is a critical period for this maturation of hearing. And if you're familiar with the management of deafness, especially in children, and for example, cochlear implant and congenital deafness, you know that if you rehabilitate the earrings too late, you might not have as good a result as if you do it like rapidly during the first 2 years of life. Well, if you look at the tinnitus literature focusing on children, it seems that the development of tinnitus needs to be preceded by auditory experience, and that actually tinnitus occurs with a very low prevalence in children that do have congenital deafness compared to children that have acquired deafness or more progressive deafness. So this is somehow important and interesting from a research and physiopathological point of view. So we've seen that the prevalence in the tinnitus pediatric population is almost similar as the one that we have in the adults. So why are we not seeing as much children in consultation than adults? Maybe it is because pediatric tinnitus does not have the same clinical significance. Differences between children and adults are numerous. Children are not many adults. And actually, children do not talk about the tinnitus the way adults do, and they do not seek care like adults do. In the younger one, they might lack the linguistic and or cognitive skills to discuss or even recognize the presence of tinnitus. So that might be why they're not talking about it or not expressing the need for management about it. Also, tinnitus might be present for a long time, and the child might assume that it is a normal experiences and that everybody around them might hear the same kind of experiences. In older children, especially during adolescence, they might be reluctant to talk about tinnitus because they are fear of being judged, because they're hearing something that nobody else is hearing. So they might be reluctant to actually mention that they are hearing this kind of sound. And actually, we are not seeing or managing a lot of children with tinnitus in clinical practice, also because we are not asking the question. We are under evaluating the presence and the prevalence of tinnitus. If you start asking questions, like in a systematic interview, you ask about tinnitus, you might start to get the impression that tinnitus is more and more frequent. And actually, if we go back to this review paper, they also look at papers in which they ask for the severity of tinnitus. And as you can see, I highlighted the percentage of the children that actually said they were bothered by the tinnitus. It's around 15 to 30%. In the normal hearing, and about the same in the hearing loss. So actually, when you ask about it, children might also be disturbed by the tinnitus or by express some botherness about it. So the clinical significance actually is that for children that for whom actually the tinnitus is disabling, then the tinnitus have a significant impact on their physical and psychological well-being as well as on their learning. And that's one of the main differences I would make in between children population and adult population from a medical point of view, is that children are in construction somehow. They are learning. They are not totally neurologically finished, emotionally stable as adults. So they have a lot of different processes and regulations and learning to go through during the early childhood age and later on. And if you have symptoms or medical disorders that impact this period, these can have long-term consequences, especially if you're dealing with pediatric population. So how to be able to actually kind of get the feeling that tinnitus might be disturbing or severe for a specific child. Well, you need to address specific issues, especially in the interview or medical history review. If the child or the parents, for instance, mention sleep disorders or hearing difficulties, concentration difficulties, difficulties at school dropouts, for example, emotional impact, modification of behavior, a child that is more isolated, yes, the behavior is different, then you might have a child with a very severe or at least bothersome tinnitus. So what assessments do we do specifically in clinic, particularly as an ENT? First, you've got the medical history interview. We interview the child and the parents. And we do that, the interview is always age appropriate. I always interview the child. Even if it's 3, 4 years old, I always ask questions about his feeling, about his perception, about the kind of sound he's hearing. And I also ask the parents. Most of the time, the parent's going to start the interview. At least it's going to be the parent that's going to lead the beginning of the consultation somehow. But the real patient is the child, so I always come back to the child and ask the child to develop, or at least to let me know what exactly it is that he is feeling. So I ask questions that are very similar to the one that I would ask to adults. What kind of tinnitus they do here? When did it start? Where does it hear it? And the location, 1 ear, 2 ears. Is it all day long? Several times a day, several times a week? Does it last long? Is it associated to other symptoms? Are there anything that can aggravate or improve the tinnitus? I also ask a question about family medical history or personal medical or surgical history. I also ask questions about hearing and vestibular difficulties. Do the child have vertigo, dizziness? At what age did he start to walk independently? Is all of that normal? And then I have a few questions, or at least I try to grasp the impact of tinnitus on daily life. And this is very important because based on this, I will adapt the management and the treatment or the follow-up. So I'm looking at the level of concern about tinnitus, especially from the child, not that much from the parents, even though when you're doing a pediatric, you need to take that into account because if a consultation was motivated by the parent, you also need to reassure the parents, even though the child might not be suffering much for the tinnitus, for example. But you need to disentangle the level of concern of one and the caregivers. You might also want to have kind of a feeling of the psychological profile of the child. Is it a child that is kind of shy or anxious, or is it a high-profile child? Do you see sign of autism, for example? There's a lot of different information that you can get only by the interview. Do they have school-related issues, school dropouts, for example? Did the parent observe behavioral changes? How is the sleep? And you can also use questionnaires, and the easiest way to evaluate the intensity of tinnitus or the botherness of tinnitus, it's probably the visual analog scale in the pediatric population. So after that, we do obviously an audiometry evaluation. So we test the audition of the child, always adapted to the child. So we might not be able to do all and every test that we do in the adults, but we do auditory threshold in the classical frequency up to 8 kilohertz, and then we try to do evaluation of high frequencies if it is possible, if the child is able to do it, if he's got enough attention to be able to manage a longer examination period. You can do autoacoustic emissions, tympanometry, and then you can also do some tinnitus evaluation about the frequency, the loudness matching of the tinnitus. It is already difficult in the adult population, so in younger children it might not be possible or hardly feasible. And then you can try to grasp the impression if they have hyperacusis, where is the comfortable or uncomfortable loudness level. You have the NT examination. Obviously, you do otoscopy. You are looking in the child at serous otitis media or a wax plug, because sometimes only that is the reason of the tinnitus, and then you have the cause and you have the treatment that is ready for you. And I also do some TMG evaluation and dental examination, especially because you have somatosensory tinnitus, and also because around the adolescent period, a lot of the child you have dental braces and go through a lot of dental management. Do I do imaging? Very rarely in the pediatric population. I do it if the tinnitus pursuit is mostly unilateral, if I do have hearing loss, or if the tinnitus is pulsatile. And if I do ask for imaging, I preferably ask for MRI. So this is the basic evaluation of the pediatric population that I do. And what about the management? What about the treatment? Well, regarding treatment of tinnitus in children, there are no consensus published in the literature, which is not a surprise, since there's not much consensus for the adult population. And research on management and treatment of tinnitus in children is even less frequently published or looked at. So what I do is a lot of explanation. I give advices and information. So I do a lot of reassurance. The main differences, as I said, between adult and children is children manage the tinnitus a lot more different than the adult do. And most of the time, only reassurance, explanation, and a normal hearing evaluation is sufficient to for the tinnitus to not be put in front, and for the child to be reassured, and also for the parents, actually. I provide some strategies if they have difficulties going to sleep to help for this moment. And I do communicate for the child. I use a child-friendly vocabulary, but also I do communicate with the parents. If I find hearing loss, obviously I'm gonna prescribe hearing aids. This is gonna be the first line of treatment, and this is gonna help the child from a hearing perspective, but also for the tinnitus. We might try some sound enrichment therapy or audiological therapy if the tinnitus is really bothersome, and if the child wants to pursue some kind of therapy. I pay a lot of attention also to the psychological consequences of tinnitus. If I have signs that the tinnitus might be severe, or signs that the psychological aspect of the child is not perfect, then I will ask for professional colleagues that are specifically trained for psychological management of children. So if I have sign of depression, anxiety, if I do find self-harm or suicidal thoughts, if it's a child who's not going to school anymore, if there are significant family problems, then I do orient those child to colleagues. Management of somatosensory tinnitus, I look at this also in the child. I look at signs of bite marks or a modification of tinnitus when they're doing some jaw movement, for example. Medication, at least using drugs in the child, I'm not doing that a lot at all. It's very exceptional. Sometimes I use melatonin for the one that I've trouble falling asleep. And if there is psychological trouble, then I refer the child, as I said, to a psychiatrist or neuropediatrician, and they might add some drugs like anxiolytic, antidepressant, or other if it's necessary. If you're interested in tinnitus and the management of tinnitus in the clinical settings, I found this guideline very practical and very useful when I started to see a lot of child in my practice. So don't hesitate to look up for this practice guidance, which is really nicely done. And if we have a little bit of time, I don't know, like five minutes, do we? I might show you some clinical cases just to give you a sensation of what kind of children I see in consultation, or you might get that have tinnitus. So the first case is 10 years old girl. She's got tinnitus for about a year. It's a bilateral perception, more on the right here. And it's intermittent, meaning that she only got 3-4 episodes of tinnitus per week. There's no personal or family medical history. She's complaining sometimes of blocked ear or difficulty hearing, especially in school. And it was the time when we were right in the COVID period, and she said, I've got difficulties, especially since we're using the mask. Before that, she was not that bothered. But during the interview, she came for tinnitus, but mostly she talked about auditory discomfort and auditory difficulties. So I did the evaluation, the otoscopy was normal, tympanometry was normal, but when I did the hearing evaluation, I got a hearing loss on both here. If you're not familiar with the way we represent the results of audiometry, you've got in red the right ear, in blue the left ear. Each circle or each cross is one of the sound that we've tested. Here you've got the frequency of the sounds, and here you've got the decibel scale. So as you can see on the right and on the left, she's got the hearing level at about 45, 50 decibels. So she's got a moderate hearing loss and difficulties to repeat words that I provide her in the auditory booth. So what I decided to do, this is kind of a easy tinnitus consultation because I have a hearing loss associated to tinnitus. So I do prescribe conventional hearing aid that she tried, and then she liked a lot because she wore those hearing aids every day. She was very happy with the results, and the tinnitus clearly dropped in intensity while she was using the hearing aid. Case number 2, 14 years old girl again. She had tinnitus for 1 year, a bilateral tinnitus. Initially, it was only present on one ear, and she's got kind of a special tinnitus because she got 2 types of tinnitus. One is whistling, and one is kind of a windy noise. But when I asked a little bit more about this noise, she actually said that it was synchronous to the heartbeats. So always, when you ask about the kind of sound that they're hearing, always mention a pulsatile tinnitus, or at least make sure that the tinnitus they're hearing is not pulsatile in nature. Because at first she was talking about wind, but when I asked a little bit more question afterwards, she started to modify a little bit the way she was describing it, and it resembled pulsatile tinnitus. It was modified by neck movement and somehow positional, depending on the position of the head. She had a louder tinnitus perception or softer tinnitus perception. No medical history. She has already seen 5 ENTs before she came to me. Normal hearing. She already had MRI, normal dental assessment. Everything was normal. And she said she was basically bothered specifically at night when she was going to bed. And it was at the point that she was afraid of going to bed and to be in the silence at that moment, and reported and then delayed the time she was going to bed because of that. And she was very tired because of late sleeping. All my evaluation was normal. I have a normal hearing evaluation, at least in the traditional frequency, but I also do high frequency evaluation, especially in older kids that can manage to do this evaluation for a longer time. And as you can see, there's a little bit of decrease of hearing on the right side, which was the side where the tinnitus started in the high frequency. And when I did the tinnitus evaluation, it was centered to the 8 kilohertz, so right before the fall of the hearing level. So we can associate the tinnitus and the hearing loss in the high frequency. But one thing that bothered me was the fact that, well, she described two tinnitus, and one was pulsatile. And when I do have pulsatile tinnitus, I always ask for a further evaluation and imaging, for example. So I did send her to a radiologist here in Paris that is specifically trained to look at tinnitus using MRI and scan. And he did a first MRI, which was actually totally normal, but then did a scanner, and he found out something that was not expected at all in this young patient. It was the beginning of autosclerosis on both here, as you can see here on the scanner. So don't hesitate to do exams if the tinnitus is not classical, if the tinnitus is pulsatile, because you can find some interesting condition or like condition that you were not expected at the beginning, especially here because she had the normal hearing. But the way autosclerosis might provide pulsatile tinnitus is first through conductive deafness, which is not actually the case in here, but also through the physiological process like hypervascularization. So be aware of the different evaluation that you might do for pulsatile tinnitus, especially since some of the cause of pulsatile tinnitus might be life-threatening. And I think I'm going to stop here because it is time.